Hi everyone, today we'll be discussing analgesics. I am a postgraduate student at Department of Oral and Maxillofacial Surgery at Institute of Dental Science. So what is pain? A pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. It is a definition which is accepted by World Health Organization. Analgesics. So it is a drug that selectively relieves pain by acting in CNS or on peripheral pain mechanisms without significantly altering consciousness. WHO pain ladder. So according to this, the general principle is to start with the first step drugs and then to climb the ladder if pain is still present. First of all, we will be choosing a non-opioid according to the indication, not blindly. Secondly, we will be choosing a weak opioid. Thirdly, if the pain persists and increases, then we will take a strong opioid. Pain process. So there are four phases of the pain process. How the pain is transferred towards the brain and felt: transduction, transmission, modulation, and perception. First phase includes transduction, that refers to the process by which tissue damaging stimuli activate nerve endings. Transmission refers to the relay functions by which the message is carried out from the site of tissue injury to the brain regions. Modulation is a recently discovered neural process that acts specifically to reduce activity in transmission systems. And perception is the subjective awareness produced by sensory signals. It involves the integration of many sensory messages into a coherent and meaningful system. So here comes how the pain is transferred to the sensory cortex. So pain can basically be broadly categorized as the pain from a sharp object, or a pain from touch, or pain from a noxious stimulus. So if a noxious stimulus, if we say like a pin, so when a pin hits a finger, nociceptors activate in the regional area. Then the pain is transferred via the A delta and C fibers. Similarly, the mechanoreceptors sense touch, and A beta fibers transfer them towards the dorsal root ganglion. Then from the dorsal root ganglion via the spinothalamic tract, it travels towards the thalamus and finally towards the sensory cortex, where it's interpreted as pain. So this is the pain measurement scale. So uh, how do we know a patient is in pain? So first of all, we will see secondary symptoms a patient is trying to tell us, or they're on the face of the patient. So there is one classification which is shown above, that according to the facial expressions, how do we classify that at what level of pain the patient is in? So this is a small diagram I have made, flowchart of classification of analgesics. So the analgesics can be broadly classified as opioids and non-opioids. Opioids meaning narcotics or morphine-like, while the non-opioids, non-narcotics or aspirin-like. So opioids can be divided into three major groups: natural, semi-synthetic, and synthetic. Natural, derived from plants like morphine. Other example includes codeine, which I have not written here. Semi-synthetic includes diacetyl morphine, which is also known as heroin. Synthetic one includes fentanyl and tramadol. And in non-opioids, there are different types according to the mechanism of action each of them show. So, according to the inhibition of the cyclooxygenase enzyme, we can divide them into three main subclassifications. So, the first one is the non-selective COX inhibitor. Second one is preferential COX-2 inhibitor, selective COX-2 inhibitor, and analgesics, antipyretics with poor anti-inflammatory action. So the main example of preferential COX-2 inhibitors is nimesulide, which is less commonly used nowadays. The selective COX-2 inhibitors, which are also known as COXIBs. So there are three main types, three which are commonly used: celecoxib, etoricoxib, and pericoxib. And the most, the favorite of all the doctors, the paracetamol, analgesics, antipyretics with poor anti-inflammatory action. So Coming to the structure of a plasma membrane, coming back to the physiology we used to study in the first, second years of our medical colleges, that it is a lipid bilayer. It's composed of proteins, lipids, and carbohydrates. 55% of proteins, lipids 42%, carbs 3%. So the out of this lipids, we have phospholipids, cholesterol, other lipids which are sphingolipids, which are commonly seen in nerve cells. So the main consideration we will be having in the pain mechanism will be for the phospholipids, because when the phospholipase A2 enzyme acts on the arachidonic acid, it leads to formation of prostaglandins and leukotrienes. For the formation of prostaglandins, we require COX enzyme, while for the formation of leukotrienes, we need LOX enzyme. For COX, it refers to the cytooxygenase enzyme, while for the LOX, it refers to lipooxygenase enzyme. So the COX enzyme is also of two types, COX-1 and COX-2. So the formation of arachidonic acid from the membrane phospholipids after a tissue injury can be minimized on application of steroids, because steroids are anti-inflammatory in nature. So coming back to this phospholipase A2. So phospholipase A2, considering this small guy, is set says that I set the arachidonic acid free from the tyranny of the phospholipids. I let the amino acids loose to promote my agenda, that is the inflammation. However, steroids can send me back to the cleaners. So actually, this meme is not made by me. I've taken this somewhere from a YouTube video, but it seemed to be interesting, so I added this to my slide. So this is the basic mechanism of the formation of prostaglandins. There are two main types of prostaglandins: the cytoprotective prostaglandins and inflammatory prostaglandins. So basically, whenever there is a tissue injury, there is a formation of phospholipids, which finally leads to the formation of arachidonic acid. So arachidonic acid leads to the formation of cytoprotective prostaglandins and inflammatory prostaglandins. Okay? So the cytoprotective prostaglandins protect gastric mucosa and aid in platelet aggregation, while the inflammatory prostaglandins recruit inflammatory cells, sensitize skin pain receptors, and regulate hypothalamic temperature control. So the COX-1 is inhibited by both the NSAIDs and aspirin, and COX-2 as well. So the cytokines and growth factors are main inducers for the COX-2 enzyme. So here we can see the same diagram again. And so the here we have seen the lipooxygenase enzyme. So the lipooxygenase enzyme leads to the formation of leukotrienes. So leukotrienes is a very bad for asthmatics. So it needs to be under the control. Both COX-1 and COX-2 produce prostaglandins that that cause pain, fever, and inflammation. So the basic ideology behind all this was that we have to prevent either the COX-1, COX-2, both of them, or either of them, to reduce the pain, fever, and inflammation. So the features which are unique to COX-1 include that it produces the thromboxane A2, which activates platelets and causes procoagulation. That is, it promotes coagulation, while and also it produces the prostaglandins that protect the stomach epithelium from acids. Here is an easy diagram how we can remember the COX-1. First of all, I am showing a finger here. A finger, let me make a pointer. Let me take out a pointer from here first. Wait. Oh, I'm so sorry. Pointer is not available at the moment. Okay. So now coming to the non-steroidal anti-inflammatory drugs. The non-steroidal anti-inflammatory drugs are among the most widely used classes of drugs for the management of acute and chronic pain in dentistry. In contrast to morphine, they do not depress the CNS, do not produce physical dependence, have no abuse liability, and are weaker analgesics except for inflammatory pain. They are also called non-narcotic, non-opioid, or aspirin-like analgesics. So, the four major actions of NSAIDs are the analgesics, antiplatelet, antipyretic, and anti-inflammatory action. So the two types of NSAIDs, these are the major classification. Uh, these are the most commonly used NSAIDs. So the first one includes the classical ones, and the second one includes the newer ones. The classical ones include the non-selective COX inhibitors like aspirin and ibuprofen, while the second one includes selective COX-2 inhibitors. It can also be known as anti-COX-2, and the first one can also be known as anti-COX-1-2. So, so the first one, the classical one, increases the peptic ulcers and increases the bleeding. So it should be avoided in cases of the patients who have a history of either increased gastric production, gastric acid production, history of peptic ulcers, and history of bleeding disorders. And the newer ones, the selective COX-2 inhibitors, decrease the risk of peptic ulcer and but increase the risk of clotting. So here we can also see that it should also be precautiously used in patients. It might be harmful for them. For example, in cases of myocardial infarction, atherosclerosis, so let us come to some clinical examples. So patient with arthritis and history of peptic ulcer, he or she wants NSAID for pain. So here we have selective COX-2 inhibitors like celecoxib. And for post-surgery pain management, what should be used? Aspirin can be used because it inhibits the thromboxane A2. It promotes clotting post-surgery, and which is the main aim of post-surgical patients, that the dissected tissues and the wounds which are created by the surgeons are healed properly without causing any post-operative complications. Now coming to the non-opioids classification. First of all, we have the non-selective COX inhibitors. Non-selective COX inhibitors. So many of we can classify this as an iOS AP. So we can take an iPhone as an example. iOS A square P cube. So first of all, we have indole derivatives, that we have indomethacin. From I, it starts the indole derivatives. I starts the indomethacin. Oxycam derivatives. We have a cam in the name of both the derivatives and the product, that is piroxicam and oxycam. Salicylates, we have aspirin. Antranilic acid derivatives like mefenamic acid. Aryl acetic acid derivatives, diclofenac, aceclofenac. Pyrolo, pyrrole derivatives, ketorolac. Propionic acid derivatives, ibuprofen. Pyrazolone derivatives, phenylbutazone. So the other ones include preferential COX-2 inhibitors, which is the nimesulide, selective COX-2 inhibitor, celecoxib, etoricoxib, pericoxib, analgesic, antipyretics with poor anti-inflammatory action, paracetamol. So the non-selective COX inhibitors block both the COX-1 and COX-2 enzymes, while selective COX-2 inhibitors block only the COX-2 enzyme. Preferential COX-2 inhibitors are in between, showing a stronger preference for inhibiting COX-2, but still affecting COX-1 to some extent. So the non-selective COX inhibitors inhibit both COX-1 and COX-2 enzyme. Preferential ones include COX-2 more strongly than COX-1, and the selective COX-2 are highly specific inhibitors that block only the COX-2. So the mechanism of action of NSAIDs is that when the arachidonic acid produces prostaglandins, prostacyclin, thromboxane A2 via the cyclooxygenase enzyme, which has two isoforms, the constitutive and the inducible. The constitutive named as COX-1, inducible named as COX-2. So the NSAIDs inhibits them non-selectively. If we talk about the mechanism of action of aspirins, it also inhibits the COX enzyme, since it is a COX uh, non-selective COX inhibitor, so it can block both COX-1 and COX-2. So it works by acetyling the serine residues, and prostaglandin inhibition causes analgesia, antipyretics, anti-inflammation, and antithrombotics. So the mechanism of action, um, basically they act on the peripheral pain mechanism. NSAIDs block the pain sensitizing mechanism by inhibiting of PG synthesis and other pain electing substances. So, but lately the central component of analgesic action of NSAID has also been shown to involve inhibition of PG synthesis in the spinal dorsal horn neurons as well as the brain. CNS component also rise the brain threshold. Now coming to the salicylates. So aspirin is an acetyl salicylic acid. So analgesic, antipyretic, anti-inflammatory action. Here we can see the diagram of its chemical structure. And aspirin resets the hypothalamic thermostat and rapidly reduces fever by promoting heat loss by sweating, cutaneous vasodilation, but does not decrease heat production. So it has an anti-inflammatory action which is exerted at high doses, that is 3 to 6 grams per day. Signs of inflammation like pain, tenderness, swelling, vasodilation, and leukocyte infiltration are suppressed. So this chart you can refer for the dosage for analgesic, antipyretic, acute rheumatic fever, and osteoarthritis. It would be beautiful if you people take the screenshot of them and keep it stored in your beautiful mobile phones. Propionic acid derivatives. Ibuprofen was introduced in 1969 as a better tolerated alternative to aspirin. The antiplatelet action ibuprofen is short as compared to aspirin. So ibuprofen has been found equally or more efficacious than a combination of aspirin plus codeine in relieving a dental surgery pain, but is a weaker anti-inflammatory, not suitable for acute gout and other similar conditions. It has been rated as the safest traditional NSAID by the Spontaneous Adverse Drug Reaction Reporting System in UK. So dosage is 400 to 600 mg TDS. And coming to the pyrrolopyrrole derivatives, we have ketorolac, and the most favorite analgesic of all the dentists. It is a potent analgesic and modest anti-inflammatory activity, longer duration of action. Its trade name, which is available, is ketorolac. Its use is frequently used in post-operative dental pain, renal colic, migraine, bony metastasis. Dosage recommended for short-term management of moderate pain is 10 to 20 mg 6 hourly orally. Adverse effects we can see here it's written like nausea, abdominal pain, dyspepsia, ulceration, loose stools, drowsiness. Aryl acetic derivatives. Aryl acetic derivatives include diclofenac sodium, an analgesic, antipyretic, anti-inflammatory drug, a preferential COX-2 inhibitor. The antiplatelet action is not appreciable due to sparing of COX-1. It also does not block the cardioprotective effect of low-dose aspirin. Its trade name is Voviran or diclofenac. Here we can see a Voviron SR sustained release 100 mg tablet. It should be avoided in children, pregnant women, nursing mothers, renal disease patients, and 50 mg TDS, then BD orally. But the weight consideration should always be seen before administering any sort of medication. Always, always take the weight of the patient into consideration, no matter what. So there is an article which compares the paracetamol, ibuprofen, and diclofenac sodium for pain relief following dental extraction and deep activity preparations. To compare the effectiveness of different oral analgesics for relieving pain and distress in adults following the extraction of teeth and deep cavity preparations under local anesthesia, and concluded that diclofenac potassium was more effective than paracetamol or ibuprofen for reducing post-operative analgesia in adults who are having teeth extracted. So coming to the selective COX inhibitors, because of the theoretical advantage of inhibiting COX-2 without affecting COX-1 function, some highly selective COX-2 inhibitors have been introduced over the past 2 decades. They cause less gastric mucosal damage, occurrence of peptic ulcer, and ulcer bleeds in clearly lower than with the traditional NSAIDs. So currently, three selective COX-2 inhibitors, also known as COXIBs, as discussed earlier, like celecoxib, etoricoxib, and pericoxib are available in India. Rofecoxib and valdecoxib were withdrawn within few years of marketing for increasing cardiovascular risk. Para-aminophenol derivatives, the paracetamol, acetaminophen, and the deethylated active metabolite of phenacetin. So these actions include analgesic and antipyretic and negligible anti-inflammatory action. So the combination of aspirin and paracetamol is additive analgesic effect is obtained when the total amount of aspirin plus paracetamol is 1000 mg. Here I have also included the chemical structure. So these are the pharmacokinetics, uses and dosage and adverse effects. You can take a screenshot of this page as well. The NSAIDs used most commonly in dentistry for mild to moderate pain with inflammation include paracetamol, low-dose ibuprofen, and the post-extraction similar extraction pain, the ketorolac, ibuprofen, diclofenac, aspirin. The gastric inflammation to conventional NSAIDs include toricoxib, paracetamol, anaphylaxis, asthma, nimesulide, COX inhibitors can be used. In pediatric patients in pregnancy, paracetamol is used. These are the adverse effects of the NSAIDs. I have made an easy diagram in the next slide. So this diagram you can use for an easy explanation in your theoretical exams. So this is an easy way to remember that there are two things to be said of while thinking of administering the NSAIDs. Don't you shouldn't be sad after administering the NSAIDs. Always when you administer any sort of these drugs which might harm the patient's gut or any major side effects like rashes, phototoxicity, hepatotoxicity, Ray's syndrome should always be kept in mind before administering NSAIDs. So there are two things to be sad of: the adverse effects and the contraindications. The gastric adverse effects include nausea, vomiting, gastritis, peptic ulcers, rashes, phototoxicity, hepatotoxicity, and Ray's syndrome. And contraindications includes the BCBCG, that includes bleeding tendencies, chickenpox, breastfeeding, chronic liver disease, and G6PD deficiency individuals. So opioid analgesics, as discussed earlier, natural, semi-synthetic, and synthetic. Natural ones include morphine, semi-synthetic ones include diacetyl morphine, and synthetic ones include fentanyl, tramadol, opium. So these opioid analgesics are mainly produced from the opium, as we can see here. It's in Hindi written the afim. It's a plant Papaver somniferum. So dark brown resinous material obtained from poppy capsule. So the mechanism of action of opioids is that it activates 7-transmembrane G protein coupled receptor, also known as GPCR, located presynaptically and postsynaptically. Opioid analgesics acts mainly on mu receptors, causing hyperpolarization of neurons and inhibition of nerve firing by inhibition of calcium influx. And opioids relieve pain both by raising the pain threshold at spinal cord level and altering the brain's perception to pain. So the opioid receptors, mainly three types of receptors are there: mu, kappa, and delta. Mu ones are the most commonly involved. So its location includes peripheral nerve endings, substantia gelatinosa in spinal cord, periaqueductal gray in midbrain, and brain stem, medulla, hypothalamus, and also amygdala. And the opioids are agonists, partial agonists, or competitive antagonists of the receptors. Morphine is agonist of all, but affinity is higher for mu. So the opioids activate opioid receptor. It is an easy explanation I have made in this diagram. Opioid activates opioid receptors, the supraspine, spine, and peripheral tissues. Analgesia from moderate to severe pain. It's not recommended for acute pain. And always maximize a non-opioid before adding an opioid. And it's considered safe in lactating women. So morphine, coming to morphine. Morphine is helpful in long bone fractures, myocardial infarction, terminal cancer, burns, post-op patients, visceral pains like pulmonary embolism, pericarditis. So major drawbacks are that it reduces the it depresses the vasomotor center, and also the curve center and temperature regulating center. It's contraindicated into extremes of age, bronchial asthma, respiratory insufficiency like emphysema, head injury, shock, and morphine is a strong analgesic, though dull, poorly localized visceral pain is really better than sharp, defined somatic pain. Fentanyl. So, coming to fentanyl, it's 80 to 100 times more potent than morphine, both in analgesia and respiratory depression. In analgesics doses, it produces few cardiovascular effects. Cardiac contractility and heart rate are only marginally reduced because of high lipid solubility. It enters the brain rapidly and produces peak analgesia in 5 minutes after IV injection. The duration of action is short, starts wearing off after 30 to 40 minutes due to redistribution. The transdermal fentanyl has become available for use in cancer, terminal illness, or other types of chronic pain for patients requiring opioid analgesia. Buccal use is possible but not oral. Coming to tramadol, centrally acting synthetic, atypical. Its analgesic action is only partially reversed by the opioid antagonist naloxone. So very low action on opioid receptors, effective both orally and IV. 100 mg is equal to 10 milligrams of morphine, and used in mild, more moderate trauma, surgery, cancer, and short diagnostic. So thank you for this for listening this presentation so calmly. Hope we meet again.